Good morning, everyone, and thanks again for making out this morning. I'm apologize, and I hope you can bear with me as I do this talk with my best Adele impersonation clearly today. So I'm going to talk about reflux and just provide snippets of the evidence that have come out in the last 5 to 7 years. And really, in the next 30 to 40 minutes, I'd like to go over the pathophysiology, diagnosis, and the approach in the workup of VUR, which is, believe it or not, still a contentious issue in some ways. And then I'd like to go over the evidence in the management of VUR, with antibiotic prophylaxis being in the forefront recently, and a very brief overview of VUR in the adult. I'm going to talk later that there's really very little evidence or none at all during this time as well. So VUR is the retrograde flow of urine from the bladder to the upper urinary tract. Embryologically, this is thought to occur when the ureteral bud reaches the urogenital sinus, which eventually becomes the bladder wall too soon, resulting in reflux, as the ureteric orifice tends to be more proximal and lateral, and this results in a deficiency in the function of the anti-reflux mechanism inherent to the intramural portion of the ureter of the UVJ. The clinical significance of reflux really stems from an increased risk of upper tract infection and pyelonephritis, which in turn can result in renal scarring, eventual hypertension, and renal failure in the most extreme of cases. So VUR is diagnosed by avoiding cystourethrogram, or VCUG for short. Images obtained from the VCUG are then used to grade reflux according to the standards from the International Reflux Committee. To the left of the screen, you will see the corresponding grade and description in the bottom pictorial format. For example, with grade 1 being reflux into a non-dilated ureter, in the most extreme cases, a grossly dilated ureter, pelvis, and calyces, and the loss of papillary impressions and ureteral tortuosity, here at grade 5. As with other grading systems, reflux enables the clinician to get a sense of not only disease severity, but provide some sort of prognostic value. In grade 1 reflux, for example, some reports have shown resolution rates spontaneously of up to 72%. In grade 4 to 5, as you go up, the spontaneous resolution rates decrease to about 32% purely based on grade. We now know that there are, of course, other factors that contribute to resolution, which include initial age of presentation, or whether it's unilateral or bilateral. Although VCUG is the established standard in diagnosing reflux, one of the big questions that continues to be debated is when it should be employed in the setting of an infant or child who presents with a first or index febrile UTI. And I'm going to make that distinction because we already have clear guidelines for those with antenatal hydronephrosis in the workup, because you can get posterior urethral valves or UPJO, and that's something that needs to be sorted out early on. Other tests that include in the workup of reflux are the renal bladder ultrasound, of course the VCUG, and the dimercaptosuccinic acid, or DMSA, nuclear medicine scan. I will next talk about the two most common approaches for the workup after a first febrile UTI, which is the top-down versus bottom-up approach, and I'll explain each one next. So, starting with the bottom-up approach, this approach revolves around performing a VCUG after the first presentation of a febrile UTI in an infant or child. This was endorsed in the American Academy of Pediatrics practice guidelines in 1999. Of note, these guidelines were recently updated in 2011 and were changed accordingly as follows. Now they recommend that infants or children who present with a first febrile UTI, that they should get a renal bladder ultrasound. And if there's any abnormality in the ultrasound, then you can proceed into performing a VCUG. From my readings for this topic, it was interesting to note the number of rebuttals and published papers that aim to support the original and true bottom-up approach in 1999, which is VCUG from the get-go. So the rationale for bottom-up approach stems from our understanding, really, that patients with VUR are significantly more likely to have acute pyelonephritis and renal scarring than those without. Scarring was most associated with higher grade of reflux. Considered clinically significant in literature are the ones that are grade 3 or more, also described as dilating reflux. The bottom-up approach will thus readily identify reflux in this setting, and then one can then treat appropriately and accordingly in a timely manner. So it was no surprise then that when they published guidelines in 2011 saying that we should do an ultrasound first before VCUG, that this caused some discontent and debates between healthcare providers, including some urologists, especially in the States. Some feel that performing an ultrasound first may encourage pediatricians and other primary care providers to put off the VCUG, especially if they have a normal ultrasound. So what this group from Vanderbilt did was that they retrospectively looked at patients, infants and children who presented at their institution with a first febrile UTI before these guidelines were published. And 95 of 154 patients had a normal ultrasound, and they focused on these patients themselves. And they found that these patients got an eventual VCUG purely based on the previous guidelines, bottom-up approach, and about a quarter of them, or 24% to the right, have dilating vesicoureteral reflux, something we would consider clinically significant. And they argued that, if you were to continue with this ultrasound first and VCUG later, you would have missed, a quarter of the patients at the very least. Of course, most workups have its own disadvantages. And with regards to the bottom-up approach, the VCUG can be quite traumatic, especially for those that are toilet trained. And then another group, this one from Boston, then looked at the potential for overtreatment. Are we finding reflux that are otherwise not clinically significant, or we don't need to do anything about? So they did a prospective trial of 309 children, aged 1 to 24 months of age, with an initial presentation of a febrile UTI. And as you can see to the right with their results, over 60% of them actually had no reflux at all, and a majority of them had grade 1 or 2 reflux, very low grade reflux. And again, this is their argument that, do we need to do something about it, or are you performing a test that over 60% of patients don't even have? So then you go to the other side of the coin, which is the top-down approach for workup. And really this stems from the belief that renal parenchymal infection increases the risk for renal scarring, rather than simply having VUR. The goal of this approach then is to identify those patients that have renal parenchymal involvement during an episode of a febrile UTI. The thought is that these are the patients that are at risk for getting complications of VUR later on. A DMSA nuclear medicine scan is performed to assess acute renal inflammation and detect previously established renal scarring. And this is really one of the first tests instead of a VCG to be performed. This is one of the published papers that support this theory. And this was of a group from Sweden who performed a prospective trial involving children with their first presentation of febrile UTI. All children underwent DMSA renal scan within 5 days or so of fever or symptoms, and a VCUG within 2 months later. In total, 290 infants less than 1 year of age were included. Those with anatomic abnormalities, poor fever documentation, normal urinalysis, or non-culture proven UTI were excluded. What they found was that in patients with a febrile UTI in a normal scan to the left-hand side of the screen, only one had VUR that was grade 3 or higher. Again, what many consider clinically significant. You would also save performing a VCUG on about half of these patients. Then they reported sensitivities for an acute phase DMSA and detecting clinically significant reflux based on this, and this was at 96% and a specificity of 72%. Now, similar to the bottom-up approach, there's also some disadvantages to this method of going about things. One is DMSA is a 10-fold higher radiation dose than the fluoroscopy they use for VCUG. If you look at the numbers, though, overall it's still quite low compared to last week's talk when they were talking about CTKUV and all the other modalities, but it is higher compared to VCUG. You also need IV access, which can also be traumatizing to infants or kids, and there's also a lack of availability in all centers. At BC Children's, I looked at Dr. McNeely, the most recent UTI sort of workflow and guideline, and what they employ is sort of a modified top-down approach, doing imaging first as well with an ultrasound or VCUG, and then going about afterwards. This then leads us to what we do next. We finally diagnose reflux, and what are the treatment options available? So I borrowed this slide from one of Dr. Afshar's talk because it really highlights the roller coaster of how we see the disease and how we tackle it. From, as you can see in the left-hand side, treat it with cold steel, perform re-implants, do open surgery, and then it evolved into antibiotic prophylaxis, went back and forth. Then the new kids on the block came in 2001 for pediatrics anyways, which was deflux or endoscopic therapy. So starting off was an article published in 2014, the New England Journal of Medicine. And really, this article got a lot of press from the pediatric group because of the methodology employed, the number of patients they got, and the design of the study itself. So this study was a multi-site, randomized, double-blind, and placebo-controlled trial that sought to answer whether long-term antibiotic prophylaxis was effective in preventing febrile or symptomatic recurrences. Children diagnosed with VUR after their first or second febrile UTI were recruited, age range from 2 months to 71 months, and reflux range from grade 1 to 4. Exclusion criteria is written down on the left-hand side. These children were then randomized to receive antibiotic prophylaxis with trimethoprim sulfamethoxazole versus placebo. They then performed DMSA scans to evaluate renal scarring at 1 year, then at 2 years, which was a study endpoint. So it was a 2-year follow-up after all of this. Their primary outcome, as mentioned, was febrile or symptomatic recurrence, and secondary outcomes being renal scarring, failure of prophylaxis, and antimicrobial resistance, which is one of the questions that was always been raised with antimicrobial prophylaxis before this study. Treatment failures were defined as 2 febrile recurrences, 1 febrile and 3 symptomatic recurrences, or 4 symptomatic recurrences over the course of a study, or new or worsening scarring at 1 year. Again, very defined criteria. To look for resistance, they perform rectal swabs at baseline, and then again after either treatment failure or at the end of the 2-year study. They tested for E. coli resistance in that case. A total of 607 patients met the inclusion-exclusion criteria and were included in the analysis. Something to highlight is that an overwhelming of the majority of patients were females, and that the most common grade of reflux was in the grade 2 to 3 range. Looking at this, the results, we find that antibiotic prophylaxis reduced the incidence of recurrent febrile or symptomatic UTIs. And that's within the red box at the top of the screen. These were just, in terms of each subpoint, was just whether they included some of the missing data in their intention to treat analysis or not. But you can see on the left-hand column that antibiotic prophylaxis, regardless of whether you included them or not, the lower recurrence rate versus placebo. At the bottom of the screen, you'll see that antibiotic prophylaxis increased the presence of resistant E. coli in their swabs that they detected. With regards to effect modifiers, meaning what other factors have been found to contribute to recurrences, they found that children with higher grade VURs, grade 3 or 4, were more likely to have a febrile or symptomatic recurrence than those with grade 1 or 2, which intuitively makes sense in terms of if you consider the grade 3 or 4 as the ones that were clinically significant to begin with. What they also found, though, was that children with bladder and bowel dysfunction were also more likely to have UTI recurrence at the bottom red box there. So really, from this set of study, what we can get was that antimicrobial prophylaxis reduced the risk of recurrence in patients with VUR by about 50%. Prophylaxis was especially effective in children with baseline bladder and bowel dysfunction and a febrile index infection. Antimicrobial prophylaxis, interestingly, had no effect in reducing renal scarring. This was at 1 and 2 years. And that higher rates of resistant E. coli were found in the prophylaxis group versus the placebo group. Then I proceeded to look at what about those with just clinically significant, which is grade 3 or 4, dilating vesicoureteral reflux. And this was the Swedish reflux trial published in 2011. And really, this trial predated the river trial that I just showed. And the question they wanted to answer was whether antibiotic prophylaxis or endoscopic injection improved the risk of UTI recurrence in those with clinically significant VUR. Infants 1 to 2 years of age were recruited and followed for 2 years. Same as the previous study. So, complicated slide, but I'll break it down. On the left-hand side, you'll see that the red bars indicate no VUR. The black bars at the bottom indicate grade 2 to 4 VUR, and the dotted bars in between indicate grade 1 to 2 VUR. And this was basically reflux grade after 2 years when they reassessed these patients. You can see in the middle, which was the endoscopic treatment group, that endoscopic therapy with deflux resulted in reflux resolution or at least downgrading. On the right-hand side, that figure of the 66 total patients that were randomized to endoscopic treatment, after 2 years, there was about 20% recurrence in grade 3 to 4 reflux. When they looked at their outcome of interest, which was recurrence of febrile UTI, they found that endoscopic treatment or antibiotic prophylaxis significantly decreased recurrence versus surveillance. It's on the left-hand side. This data is concordant with the findings from that of the river trial, which was again published a few years after. The antibiotic prophylaxis decreases the risk of UTI recurrence, and this can be and this is true for those with higher grade refluxes as well. But from this trial, we see that despite endoscopic treatment downgrading or resolving reflux more than antibiotic prophylaxis or surveillance, endoscopic treatment was not superior to antibiotic prophylaxis in preventing febrile UTI recurrence. Again, just to highlight the key points, prophylaxis or endoscopic therapy reduced the rate of UTI recurrence. There was still a 20% chance of a recurrence of reflux after endoscopic therapy. There was no evidence for antibiotic versus endoscopic injection, so one is better than the other. Moving on then is that, beyond the antibiotics, what else do we have in our armament? I then looked at, the surgical management of VUR, and before, open anti-reflux surgery with either intravesical repair or extravesical repairs were the most common procedures, or arguably in pediatric urology. And some of the literature shows that resolution rates were as high as 98%. Surgical management would be for those usually that have either breakthrough febrile UTIs despite antibiotic prophylaxis, or those that present with a high-grade reflux already to begin with, and other factors that tell the clinician that this is probably not going to resolve on its own. For example, bilateral reflux or those with concurrent renal abnormalities. In 2001, Deflux was the first bulking agent to be approved for treatment of VUR in pediatrics. Success rates that were reported after one injection was about 83%. Not as good as the open surgical repair, but definitely less invasive in a sense. Ideally, what you want from a bulking agent is biocompatibility, has to be non-toxic, has to be non-migratory, doesn't go anywhere, non-antigenic, and causes minimal inflammation and maintains shape and volume or durability.
If you make that comment, how are you defining success?
So in terms of, from a lot of the studies when they looked at success was, from this particular one, if I remember correctly, was resolution of reflux. But again, this is in years from now, and we could already see from other studies that after a few years it can still come back. Moving on, in terms of deflux, how it's applied, it started off by using the sting procedure, or suburethric transurethral injection on the left-hand side. Basically, you go around the 6 o'clock position, just distal to the ureteric orifice, and inject the bulking agent. Then there's other modifications to this, with the more common one being the HIT, or hydrodistension implantation technique, whereby in this technique, the ureteric orifice is hydrodistended with irrigation from the scope. A bulking agent is then placed along the entire subureteral tunnel, which is believed to lead to greater ureteral wall coaptation. That's the pictorial format on the right side. Then I asked myself, is there one method that's better than the other? Sting versus HIT, does it matter? So this was a prospective trial done in Portland, and the objective really was to compare the success rate of sting versus HIT procedures. And they wanted to identify the variables that may contribute to success or failure from these. Exclusion criteria included patients with secondary reflux, so those with neurogenic bladders, for example, believe that the reflux was because of that. Grade 5 reflux, as this was a non-FDA approved indication according to them, and functional or anatomic urinary tract abnormalities. So they had 163 patients that were already scheduled for deflux, and then the first 50 patients they performed sting procedure, and the next 113 they performed the HIT or modified sting procedure. This was done by the same surgeon. They then did VCUG at 3 months, along with a renal bladder ultrasound to assess for hydro, and then the size of the deflux mound as well. Success was defined as the absence of VUR on VCUG, again only at 3 months. What they found was that reflux resolution rate did not differ between the sting and HIT procedures. With regards to the sting procedure, the volcano mound morphology was the greatest predictor of success. For the hydrodistension procedure, the HIT, lower pre-op VUR was the greatest predictor of success for this procedure. Resolution rates on the right side again shows that there is no difference, and that's the one with the red box between between sting and HIT. In their study they reported no complications from the procedure. But as we know, nothing is free in medicine. There's always a downside to everything. And I had to look at other sources, but potential complications of endoscopic therapy include obstruction, flank pain, UTIs, and of course treatment failure or persistent reflux. Then I looked at, what about moving on reflux in the adult? And the reason being is there's not much out there, and is this even an entity in itself? When I looked at the data for reflux in the adult, surprisingly, I don't know which way to do it, but there was actually pretty much none in the last 7 years that reported a prevalence. There was no trials to say how to best manage these patients. There's no trials that followed these patients. What are their complications? What do they suffer from? In fact, the last published guideline or anything of any sorts was in 1998, and this was in the form of an AUA update. At that, they said, no medical management is needed. VURs grade 1 to 2, and no history of UTI. And again, this is for primary reflux. Medical management with lifelong is what they put. Antibacterial prophylaxis should be considered in those with low-grade VUR, shortened life expectancy, and poor surgical risk. Surgery was indicated in VURs grade 3 or higher, or history of recurrent pyelo, and evidence of nephron loss. Pretty radical compared to how we've gone through from the pediatric world. In terms of their clinical manifestations in the adult, initial symptoms and finding include recurrent UTI, asymptomatic bacteriuria, proteinuria, hypertension, and renal failure. Again, these are very non-specific presentations, and this could well be due to so many factors. So I guess if you're really trying to look for it, you'd have to have this index of suspicion after you've gone through your common workup and ruling things out. Recurrent UTI or pyelonephritis is the most common indication for workup and intervention in the most recent and contemporary studies. I just wanted to highlight one such study, and this was actually a Canadian group in Quebec. And what they looked at was that this was a prospective trial involving 27 patients, median age of 23, age range 12 to 65, and those with recurrent pyelonephritis. The primary outcome was resolution or non-resolution of VUR, not recurrence of infection, which is ultimately one of the things that we're interested in. It also wasn't renal scarring. It was purely, do you have reflux or not? A follow-up renal ultrasound and VCUG was done at 3 months to see if there was resolution or not. Again, such a short time frame. But follow-up, they said, was 3 years. They kept in touch with these patients, either through office visits, not performing any investigations unless clinically indicated. They used the HIT technique, and this was purely based on preference by the surgeon. The first endoscopic injection corrected 38 of 41 ureteral units, because some patients had bilateral reflux. They also used deflux and another bulking agent called macroplastique that is not approved in children. There were 3 failures reported after their first injection. One was by a large Hutch diverticulum. One was the patient after a ureterocele incision. And apparently all went for a second injection, resulting in resolution at the 3-month follow-up. Only one febrile UTI was reported 3 years after injection, but again, this wasn't the outcome of interest, and they didn't really follow these patients looking for these actively. One patient also required a temporary double J stent for obstruction. And really, this was the most recent published data on adult VUR. And it seems like in the last 5-7 years, all the data was geared towards, does endoscopic therapy work? Can I use these deflux or other blocking agents in adults? But the outcomes that they looked at were resolution, not necessarily what many will consider clinically significant, which is the infection, scarring, and whatnot. So with that, I'm going to conclude my talk with a summary of what I just went through. This is by no means, as Dr. McNeely said, an overarching and a comprehensive review of reflux, but more of snippets of what's been out there recently. So after a first febrile UTI, a VCUG, or a DMSA scan, depending on which approach you use, can be performed as a first-line investigation. Antimicrobial prophylaxis reduces the risk of recurrence of febrile or symptomatic UTI in patients with VUR by 50%. Bladder and bowel dysfunction should be addressed to decrease UTI recurrence risk. Endoscopic management of VUR offers a durable alternative to open surgery. adult VUR is a consideration for those with recurrent pyelo. But again, the data is very limited, and you're really going into this uncharted territory of what can I do for these patients when I've tried everything. And with that, before I take any questions, I'd like to thank Dr. Afshar and McNeely for helping me put together this presentation and helping guide me and make sense of all of this after all the reading. Thank you, everyone.